Thanks very much, Annette. She actually just gave my talk, so I'm going to just sit down. I can go through my background a bit quicker now. So my mantra this morning has been people first language, but I am tired and it may slip because I'm nervous, so I'm going to try my best. Also, this conversation might trigger some people in the room who are living with HIV, so I apologize if there's any emotional distress caused, but I'm here, I'm on your side, and let's keep the conversation going forward. So the background is in 2023, I came to the workshop for the first time from South Africa, and the US guidelines were released, and there was quite a lively conversation afterwards, particularly from the low-income country attendees, about the global disparities and inconsistencies around infant feeding choices for parents living with HIV. So policies across the world vary from outright criminalization to countries like South Africa that prioritize breastfeeding even in parents who aren't fully virally suppressed. And provider practices and attitudes also vary hugely and don't always align with the current evidence base when it comes to responding to parents' expressions of wishing to breastfeed. I'm going to use parents throughout, if I remember, and breastfeeding, not breast chest feeding, just because my tongue will trip over it. The issue around this is that it perpetuates confusion. I think everyone is confused, policymakers, providers, and parents alike, and there's a lot of stigma and discrimination that parents experience. And unfortunately, the criminalization, the negative attitudes, the sort of hesitancy around breastfeeding has led to some parents hiding the fact that they're breastfeeding and not getting the care that they need. And there are two really important publications that should help to move this conversation forward. One is the Lancet Breastfeeding series, which so clearly laid out the fact that formula is not equal to breast milk. It is not a replacement. It is an inferior option when you're not thinking about HIV. And the WHO released their U=U brief, within which there was a discussion about vertical transmission risks being far below 1% in parents who are virally suppressed before delivery. So after I left the conference last year, I was kind of emotional and upset that I had learned for the first time that so many parents experience barriers to breastfeeding, and reached out to delegates within the room to ask if they wanted to take the conversation forward. So just a little bit of background about myself. I work in 3 clinics in hospitals in South Africa where I look after women who are specifically virally unsuppressed when they're pregnant or breastfeeding, or have advanced HIV with very low CD4 counts. And within the bigger picture of South Africa, we have about 300,000 women who become pregnant every year, and an awful lot of them are not virally suppressed during antenatal care, and by delivery, 12 to 15% of our women have a viral load over 1,000. And a study released just earlier this month showed that over a quarter of our women disengage from antiretroviral care during their first year postpartum. 3 to 5% of women who start their pregnancy journey HIV uninfected become infected during pregnancy and breastfeeding, and our PrEP coverage is woeful at about 6.5% of women who need it. So 30% of our infant transmissions occur in women who started their journey HIV uninfected. In terms of our breakdown of transmissions, we're doing quite well with in utero and intrapartum transmissions, but our breastfeeding transmissions contribute almost 2/3 of our infections, and we have about 7,500 confirmed infections every year, but that's an underestimate because not all babies reach the end of the testing cascade. So we think about 56% of infants are actually diagnosed. So our transmission rate is sitting at about 4%, and yet we still put breastfeeding first because the under 5 mortality from other conditions outstrips our HIV-related health burden. So this is quite a busy slide, but just see that there are so many barriers to safe breastfeeding in South Africa, and it's not because viral suppression doesn't work. Viral suppression works, but our systems, our social setting, our provider interactions, and personal factors for the young ladies and the older ladies living with HIV mean that they find it very hard to sustain that suppression during the postpartum period. So I've got a young lady I'm looking after at the moment. She transitioned from pediatric regimens to the big TLD pill that you're all familiar with now. And she kept saying to her providers, I can't swallow it, it's too big. And they said, you're grown up now, stop being a crybaby, swallow the pill. So she reached me when she was 28 weeks pregnant, unsuppressed. I split out her pills and within a month she was suppressed. We're just not listening and we're not supporting. Another lady who was expecting twins and her viral load was 1.6 million when I met her at 14 weeks pregnant, CD4 16. She was sleeping on someone's couch. She didn't have any food, so she wasn't taking her medication. Got her into a women's shelter. She takes her medication. She's virally suppressed. She delivers 2 HIV-negative babies, but prematurely. And then, unfortunately, she formula feeds, and the one gets necrotizing enterocolitis and passed away. So there's so many issues that our parents face. And yet, I'm still standing here advocating on behalf of my colleagues to support policies that enable breast and chest feeding across the world. And why is that? It's because our vertical transmission policies have 2 deeply inbuilt biases within them. One is that the parent or the mother is held lower than the infant. The infant has always been put first, even though the risks of HIV are now so incredibly low. So when you think about our approach to parental health, we gave parents single-dose nevirapine, not ART. We gave them monotherapy AZT. We told them to take ART while they were pregnant and then stopped it after the baby wasn't breastfeeding anymore. Think how much that impacted on those parents. And then we said to them, formula is the best option for you, excluding them from access to their own parental health and to socioeconomic advantages, and the infant didn't get all their other health benefits from breastfeeding. So the mum was really put low down. She was seen as a vector of disease, controlling policies, no autonomy, sexual and reproductive health rights compromised. And I would say that we need to redress that imbalance, and we need to start seeing the birthing parent and the infant as equally important, equally valued, equally visible in policies, and that their health outcomes and experiences both need to be held in equal balance. The other bias is that HIV is so important. The risk of HIV now, when you are virally suppressed for that infant, is sitting at about 2.2%. And it is a manageable, lifelong condition. So why are we so terrified of it? Because of medicalized stigma. Why is HIV so much more important than everything on the right-hand side of the slide? Parental, non-communicable diseases, cancers, infant growth, development, obesity in adulthood, sudden infant death syndrome, bonding, mental health. There's so many things that come from breastfeeding that we are excluding our parents living from HIV being able to access. And one of the challenges is the PROMISE study. It was done over a decade ago, and we are still using it as our primary source of evidence. These women started ART at 26 weeks gestation or later with a viral log of almost 4. Half of them were on AZT only during that pregnancy, and all the others were on a twice-daily regimen of lopinavir, which is a horrible drug. Most of the women that I see who are still on this, they vomit their whole pregnancy. They struggle to take it. And then in the postpartum period, they were all on that 5-pill daily regimen. And yet, in the women who were virally suppressed, there were 2 transmissions in this study that was done a decade ago with very different ART circumstances. And both of those women transmitted for obvious reasons. One had low adherence in between her suppressed viral loads, and the other one, it really looks like it was an in utero transmission that was then masked by maternal ART transmission, so baby was suppressed and rebounded later. So, high-income country policies. Just a shout out to all my colleagues. They have worked for decades to even get breastfeeding to be permissive, to not be criminalized. But our policies still have a very long way to go. When you think about a parent who just wants to breastfeed their child and then look at the list of hoops that they have to jump through to be able to do that, and then you wonder why they don't stay suppressed. How are they supposed to engage in a trustworthy way with their provider when they have all these worries on their mind? They are being told, first and foremost, that formula is their safest option. That's at the first sentence in a number of the high-income country policies. Then they're told that they shouldn't breastfeed for too long because the risk goes up over time. Is that still evidence-based if they sustain suppression? Why would the risk go up over time if they're virally suppressed? They still have disrupted breastfeeding experiences if they have mastitis, if the baby has tummy issues, or they do. How many of you in the room who have been able to breastfeed have had a baby with runny poo? And then they get told that if baby has diarrhea, they must disrupt their breastfeeding. A new mum doesn't know if that's diarrhea or if it's just breastfeeding poo. And how many mums have irritated breasts because they aren't taught how to latch? Then you go on to this intensified infant and parent monitoring. And on the one hand, you're saying, yes, you can breastfeed. And on the other hand, you're saying, but we've got to keep a really close eye on you. And we have to test your viral load every single month. And we're going to test your baby every 2, 4, 6 weeks. Because what happens if baby gets infected? And then there's a multidisciplinary approach where the parent has to engage with a pediatrician, an obstetrician, an HIV specialist, their primary healthcare provider. And when I read the protocol, the guidelines, I think, this sounds a bit like someone in jail going to a parole board and justifying their rehabilitation and release. I have to justify to all these providers that I am worthy to be able to breastfeed. No, it's not okay. You can see I'm quite emotional about it. And so there is this parent-centered and shared decision-making, but is it? So we have to maintain progress, and what I would say is that we have to start rebuilding trust. Breast or chest feeding can and is safe, but we have to enable parents to stay suppressed in order to do it safely. And how do we do that? We do it with information. We've got to get the information out there, and it has to be unbiased and balanced information. Then we have to offer true choice, not coerced choice. And we need to move from permissive guidelines to truly supportive guidelines. Great, you're going to breastfeed. Let's do this together. We can do it safely. So, Inform was born. And it's an amazing group of people. I'm going to ask those in the room who are members to please stand up so that people can see you. We've got a group of people living with HIV. We've got providers and clinicians. We've got policy contributors, and I'm truly humbled that there are so many people from high-income countries who are driving the policy change who've joined this group. It shows that they are willing to make progress, but we need to help them to do it. So we're aiming to reframe global guidelines to come up with an optimal scenario that can be true in any circumstance, any context, low resource, high resource. It doesn't matter. If the woman or parent is virally suppressed, we should be able to give them the same advice wherever they are in the world. Really meaningful and collaborative community engagement. The WHO is busy with doing their guidelines at the moment, and most people don't know what's happening and who's in the room and who's making the decisions. We need to advocate for closing the research gaps where we still don't know the answers, and in particular, high-resource countries with low burden of HIV must help the high-burden countries with low resources to put together cohorts that can really answer these questions. And we have to put an end to criminalization, but not only criminalization, this whole spectrum of heightened surveillance and punitive responses to parents who want to breastfeed. So we've split the group into 3. We've got a consensus statement group who are going to release a call to action soon, we hope, with that optimal scenario. We've got group 2 who are working at taking the really complex evidence and making it accessible for policymakers, for providers, and for community members by building a repository of really well-developed communication tools. And then we've got the research group who are looking at a gap analysis and keeping their eyes and ears open for funding opportunities so we can get these collaborations up and going. So in terms of the research agenda, what I would say is we need to offer new promise. We need to look at U equals U and find funding for those multi-country databases that document feeding practices, mixed versus exclusive, viral load testing, infant prophylaxis, and in particular developing effective peer-to-peer support models that help parents in that postpartum period, because it is hectic. It's not surprising that women who've been okay when they weren't pregnant, in pregnancy, that in the postpartum period they lose viral suppression. But it's not because the drugs don't work, it's because it's hard to take the drugs without support. We need to understand the implications of mixed feeding in viral suppression. We need to understand more about parents' views, because many parents will still choose to formula feed, and that's okay. What I'm saying is that breastfeeding needs to be open to them, and we've got to do a lot of work with provider attitudes. I think two big questions also are the impacts of exposure to parental ART for the infant. Might it work enough as infant prophylaxis without the baby also needing to take syrups, which puts quite a burden on the parents? What are the issues around resistance transmission, and does it affect infants in any other way unrelated to HIV? And lastly, we've got to answer those questions about parental viral load and how often do we need to test? And when parents rebound, what do we do about it? Do we suddenly stop the breastfeeding? Do we help them to resuppress? Do we give baby prophylaxis and carry them over? And can we develop point-of-care testing that might help us to monitor more easily so there's less visit burden for those parents to have to come in, pool blood, come back for results, the anxiety around waiting for results? So just to conclude, I would say that we need to tip the balance. At the moment, we're sitting with this heavy weight of fear, anxiety, distrust around whether it is okay to breastfeed, and really the emphasis at the moment is on provider control, and what we are sort of blindfolded on everything else and just focusing on HIV. So we need to move away from fear, the need to control, and HIV as a primary focus. And we need to move towards trusting that power of an undetectable viral load and building trust and open relationships and communications between parents and providers. And lastly, really starting to acknowledge that breast milk and formula milk are not equal, and that there are huge health inequities being created by saying that formula is the same. It's as good as breast milk, because it's not. So a take-home message is that we've got, just going back to that slide that I think is the crux, and if anyone remembers anything from this talk, building trust. Breast and chest feeding can be safe if the parents living with HIV are enabled to do so safely. And how do we do that? We do it with information, and the information needs to not only be about HIV, but also all the other issues pertaining to breastfeeding compared with formula. And then we give the parents the choice, and it mustn't be coerced. It must be a true, informed choice. And lastly, support, support, support. If a parent receives enough support, and I've seen it in my clinical practice, they can have a sky-high viral load when they're pregnant, massive adherence issues, and once they get the support and they feel heard and their voice is listened to, they will stay suppressed throughout their breastfeeding period, and they will not transmit to their infant, and they will enjoy a healthy and relaxed breastfeeding journey.